Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Experts series, I have a leading expert on myelofibrosis with us, Dr. Abdulraheem Yacoub, who's professor in the Hematological Malignancy and Cellular Therapeutics division at the Kansas University Medical Center. And he's going to tell us about how he treats myelofibrosis. We love to hear it from the experts. So welcome, Abdulraheem.
Thank you very much, Ravi, for the opportunity.
So, can you tell our audience about myelofibrosis, how common it is, and what are the outlook for this disease? It's becoming a disease that more and more people are hearing about as more and more drugs are coming out.
Yes, thank you, Ravi. So yeah, myelofibrosis is an uncommon malignancy. One would say it's a rare malignancy, actually. The incidence is roughly under 3 per 100,000 person years, which runs around to be close to around 7,000 cases, new cases every year in the US, around 100 to 150,000 cases in the worldwide every year. With cancer being so uncommon, it is likely that most physicians encounter, unless you work in a high volume center, it is likely that you'll be encountering less than a handful of cases a year. So it is not a disease of high prevalence, but because of recent advances, as you mentioned, it has become very visible disease, and we're looking for those patients to try to help them given the advancement of the tools we have right now. The prognosis has changed a lot over the years. So 10 years ago, the median survival was under 5 years for all comers. Right now, the median survival is in the range of close to 5 to 10 years now for all comers. So really, there has been a significant advancement in patient outcomes over the last decade.
So, let's hear about how this has happened. So, what are your goals of treatment when you do see a myelofibrosis patient?
Yeah, so patients with myelofibrosis have very heterogeneous presentations and a spectrum of different disease burdens and wishes of care. So patients can present at lower risk disease with little disease burden, and they have emphasis that is more towards disease modulation and disease alteration to having improved survival, while some other patients have more advanced presentations and are immediately ill and have morbidities because of their disease. So it's very important that we tailor the therapy to the patient's individual needs at the time, and those will be different between different patients. But also this will be different for the same patient as they live with their disease for a long period and have a long journey with the disease. Their desires and medical needs will change with time. It's important to have an ongoing discussion with the patient regarding what is it that we need to accomplish for them and what are their medical needs. And this will change for every patient with time.
So, we're going to talk in depth about JAK inhibitors, but in a broad landscape view, can you tell us what are the drugs that you have for these patients to help them?
Excellent. So our tools to help these patients kind of start with discussing supportive care. So supportive care measures, reversing any reversible risk factors that can be contributing to their symptoms, inflammatory markers, nutritional deficiencies, growth factors to help with supportive care measures. And then our mainstay of tools or medicines to tackle the disease are JAK-STAT pathway inhibitors. And this really comes from the understanding that all these cancers have the central pathophysiology of JAK-STAT activation as the main driver for these cancers. Regardless of the driver mutation, JAK-STAT pathway inhibition is the mainstay of treating these patients. This serves as symptomatic management and disease control, but also has survival advantage in the right patients. And then our curative therapy is bone marrow transplantation. And this is a disease of late middle age, and patients, more than half the patients are conceptually eligible for transplant at presentation. And transplant evaluation should be offered to these patients for curative intent. So these are the main tools we have to help these patients, and many patients are candidate for a combination of these tools.
So let's go through the four FDA-approved JAK inhibitors and their trials that led to the approval. The first one, I believe, that's been on the market longest is ruxolitinib. Can you tell us something about this drug
Yeah,
and
so we're very
trial?
fortunate to have four different JAK inhibitors, and they're really unique drugs with unique attributes, and they provide different advantages to the patients. They're not interchangeable, and they're not me too drugs. They're really unique drugs with different attributes and different benefits. So for physicians who treat myelofibrosis, we do need to be proficient at all four and know how to apply them. There's a lot of similarities, but also enough differences between all four drugs. Ruxolitinib was the first drug approved based on the Comfort 1 and Comfort 2 studies. These studies were focusing on higher risk patients, but since then there's been many clinical trials that examined ruxolitinib in other indications, including platelet counts of 50,000 or higher, intermediate 1 risk or higher. And these studies consistently showed ruxolitinib to be an active agent. Nearly 40 to 50% of patients would achieve the primary endpoint of spleen reduction, which is meaningful in myelofibrosis. Nearly half the patients will achieve at least 50% reduction in their symptom burden. It's really one of the more active agents, and we also have identified additional gains with ruxolitinib therapy. This drug has been approved since 2011. It really contributed significantly to our understanding of the disease as the successful therapy in myelofibrosis that leads to symptom improvement and spleen reduction can actually lead to survival advantage. So patients who were treated on these studies compared to patients who were treated on these studies and then on a control arm, then crossed over, there was actually an improvement in survival of nearly 1.5 years, despite crossover in both studies. Really, a striking evidence that an excellent control of the disease leads to gains that eventually lead to survival advantage in these patients. And when you compare this to historic data, some of the patients on the comfort studies had almost double of their overall survival compared to pre-ruxolitinib era when we had no JAK inhibitors whatsoever. So really a striking survival gain for patients with ruxolitinib therapy to add on to the other clinical gains that we have. And this has become the mainstay of therapy in MF patients and also has been a platform to follow for all other JAK inhibitors and all ongoing clinical trials in terms of how we design studies to treat myelofibrosis patients.
So I think the second one that got FDA approval was fedratinib. It had a little bit of a more protracted development course. What can you tell us about this drug?
Yeah, so fedratinib is a very active JAK inhibitor. It was in development roughly at the same time as ruxolitinib, really. So the trials were running simultaneously, the Jakarta studies and the Comfort studies. So fedratinib was studied in two different doses against the control arm. Back then, there's no other JAK inhibitors approved, so a placebo was fair and ethical. This study showed fedratinib to be a very robust agent, very active agent in spleen volume reduction and a symptom improvement in these patients, which really was what we hoped for. And also the Jakarta 2 study was a second line study after Rux intolerance or resistance. Back then, the criteria were very loose to define that. But fedratinib remained to be very active agent, even in the second line setting after Rux intolerance or resistance, which really shows significant activity. As you mentioned, there were toxicities that led to clinical hold that lasted for nearly 7 years. So after the clinical hold was removed for evaluation of cases of encephalopathy, that turned out to be some of them. There was a true confirmed case and one likely case, but the rest were not confirmed cases, and they were not really in the dosing schedule that was eventually approved. This remains a boxed warning. And when we use fedratinib, we have to warn patients about it, and we have to take measures like thiamine replacement to mitigate that risk. But it remains an agent of certain benefit in a subset of patients with certain precautions. It remains an agent we use occasionally. Yeah.
So, and more recently, we had two new JAK inhibitors, relatively new ones, enter the market. The first of which is pacritinib. What can you tell us about this
Yeah, so pacritinib was also a great addition to our armamentarium. It's a very unique JAK inhibitor in what it does. So it's the most selective JAK1 sparing JAK inhibitor and JAK2 specific, unlike ruxolitinib and fedratinib, which are non-selective JAK1, JAK2, and they both have hematologic toxicity. Pacritinib, by being JAK1 sparing, does not cause significant hematologic toxicities. If anything, it causes anemia improvement, and that really is one of the unique attributes of pacritinib. So pacritinib was studied in a second-line setting with emphasis on thrombocytopenia patients. The approval pathway was also indirect as the pivotal studies were not positive. However, a subset of those studies, particularly patients treated with pacritinib 200 milligrams twice a day, who had moderate to severe thrombocytopenia, had particular benefit that was superior to the control arm that included ruxolitinib. So for a particular subset of patients with cytopenic MF and severe thrombocytopenia, ruxolitinib is a preferred therapy based on aggregate data from the PERSIST-2 study and another study called PAC203 study, with the aggregate of data showing evidence and clinical benefit and leading to FDA approval in these particular patients. To be more specific, in the right subset of patients receiving the correct dosing schedule, which is 200 milligrams twice a day, and particularly in patients with severe thrombocytopenia, splenic responses were seen in about 1/3 of patients, and symptom improvements were also seen in about 1/3 of patients, which is clinically meaningful. The biggest advantage is the lack of thrombocytopenia with this agent. It does not improve platelets, but it does not cause thrombocytopenia, which is the only JAK inhibitor with that safety profile, and also has anemia benefit in a certain subset of patients through the activin receptor pathway inhibition and hepcidin pathway. So in some patients with successful therapy with pacritinib, again, the goals of care are symptom improvement, spleen reduction, and improvement in the patient's well-being. But in addition, pacritinib offers stable platelet count and potentially improvement in anemia. So it really has a good profile that is teasing for particular patients with the cytopenic profile, especially the thrombocytopenic patients.
And obviously, the latest entrant to the market has been momelotinib, and this too has some unique mechanistic characteristics. Can you tell us about this drug?
Yeah, so like pacritinib, momelotinib is also a potent activin receptor inhibitor. So activin receptor is something we haven't really targeted much. It's not even in the bone marrow. It's a receptor in the liver. It's responsible for hepcidin production. Hepcidin production can lead to anemia in all diseases and in cancer. And blocking hepcidin production could be of benefit to improving anemia in a subset of patients with myelofibrosis, and this concept could apply to other patients with other diseases, of course. But for myelofibrosis, this benefit has been, or this pathway has been addressed by two different JAK inhibitors, and successful therapy can result in anemia alleviation in a cohort of patients. That being said, momelotinib is also a very powerful JAK inhibitor, and it really has pronounced activity against myelofibrosis for spleen reduction, for symptoms, and so happens to be a good anemia therapy. And I would like to emphasize for the last two agents we discussed, these are agents for myelofibrosis and the patients who happen to have anemia thrombocytopenia. These are not purely anemia drugs or thrombocytopenia drugs. These are cancer drugs for myelofibrosis that have favorable attributes with anemia and thrombocytopenia, and that should be the emphasis of the discussion with patients and patient care. So they also happen to be a preferred agents with cytopenia. So this is the Simplify-1 data. It was a very ambitious study. It was head-to-head comparison between momelotinib versus ruxolitinib in treatment-naive patients. The study had two endpoints, spleen volume reduction with non-inferiority to Rux, which momelotinib was non-inferior to ruxolitinib. So actually was achieved not indifferent or similar spleen volume reduction as ruxolitinib. However, ruxolitinib was the winner with symptom improvement. Ruxolitinib is really a high bar to meet to reach with symptom improvement, and momelotinib did not achieve that bar of non-inferiority. And subsequently, this study did not meet its endpoints and was negative, and this unfortunately did not lead to FDA approval. A strong signal was found is that patients who received momelotinib actually had better hemoglobin and anemia parameters compared to ROX in this head-to-head. So ruxolitinib causes anemia. We accepted that, but momelotinib doesn't. That was the really welcomed finding from that study, in addition to all the JAK inhibitor benefit they get, which led to additional pivotal study called the Momentum clinical trial, which was a second-line myelofibrosis study with emphasis on patients with anemia and high symptom burden. The comparator was danazol, which is a legitimate anemia drug. So momelotinib compared to danazol, momelotinib came out the winner in actually the primary endpoint and every single secondary endpoint. So momelotinib was superior for symptom control, was superior for spleen volume reduction, was statistically non-inferior, one would say even better at anemia responses compared to danazol, and this led to FDA approval for momelotinib in myelofibrosis, and with data from the Simplify-1, the label actually allowed first-line use and second-line use based on the data from all these studies. So this is really a unique JAK inhibitor with attributes that are beneficial for patients with anemia. And that led to the approval within the last year.
So how do you sum this all up? So how do you use all these new tools in your armamentarium now? Let's start with first-line myelofibrosis. How do you approach your patient?
Well, this is an exciting time that we actually have the privilege of discussing with each patient that there are 4 JAK inhibitors to use in patients that all have indications for first line. In real life, the decision making for us is, we go by disease risk. So patients with high risk disease, and also patients who would benefit from a JAK inhibitor. So patients with spleen and symptoms and manifestations of their disease, they would benefit from JAK inhibitor therapy. So those are the patients we emphasize therapy with JAK inhibitor. There are patients with myelofibrosis who do not have or do not benefit from JAK inhibitor therapy. So the very low risk patients, the asymptomatic patients, patients with only anemia therapy, where they could just benefit from just anemia only targeted therapy. So those patients will benefit from different tools. For patients we decide a JAK inhibitor is necessary, we have the 4 choices. And ruxolitinib, based on the abundance of data and the abundance of safety data and the survival gain, remains a significant workhorse in the majority of patients with myelofibrosis with the proliferative phenotype. Patients who have big spleens, high symptoms, and preserved blood counts, ruxolitinib remains the workhorse for these patients. Ruxolitinib is contraindicated in patients with severe thrombocytopenia under 50,000. So when patients with severe thrombocytopenia, pacritinib has been our standard therapy, and now momelotinib is approved in patients with platelet counts 25,000 or higher. So for severe thrombocytopenia, pacritinib versus momelotinib. For patients with preserved platelets, ruxolitinib has been our go-to drug. Now, the decision has become slightly more complicated given the anemia story. So now ruxolitinib causes anemia, but it causes survival, it has survival data, while momelotinib is the more recently approved agent, which is a very powerful JAK inhibitor, non-inferior to ROX with spleen, and also has anemia again. So sometimes we're factoring that in patients with anemia that is mild to moderate, maybe ruxolitinib remains our first-line therapy. For patients who cannot tolerate RUX because of anemia or already present with severe symptomatic anemia, in which RUX might make, although you achieve other endpoints, but the anemia will become worse, we are discussing momelotinib in first-line setting in these patients. So the discussion has become a lot longer now as we discuss with myelofibrosis patients what is the JAK inhibitor of choice. Fedratinib is rarely chosen as a first-line therapy. So really it's between the 3 drugs in terms of, are these more proliferative type, they need ruxolitinib? Are these the significant thrombocytopenic patients with pacritinib is the usual choice? Or for patients with who need a lot of domains covered with symptoms, with spleen, and they also had anemia and also thrombocytopenia, momelotinib is a safe choice in these patients. Now, patients live with myelofibrosis for many years. Whichever is your choice for first-line JAK inhibitor, patients will hopefully respond, but eventually will progress. And most patients in this day and age are receiving multiple JAK inhibitors in sequence. So even though we emphasize what's the choice for first-line therapy, oftentimes patients will need multiple JAK inhibitors as they in their journey with myelofibrosis.
So that brings us to the next question. How do you decide it's time to switch treatment? Some of the things could be a little confusing. Is it the disease or is it the treatment causing the issues to arise? So how do you sort through this?
So that's a very important question, and it's actually a challenge because in the disease is progressive and patients will eventually have more anemia and thrombocytopenia as they live longer. This has been described even before we had therapy for the disease. But with ruxolitinib being our usual first-line therapy, the most common side effects is anemia and thrombocytopenia. So is it the disease? Is it the treatment? It's always going to be a challenge. But again, the emphasis is that are patients meeting their stated goals? The goal is to improve quality of life, control the spleen, patients living longer. If patients are achieving that, that's great. If they're not, then therapy is not successful. Now, if patients are achieving that and they have toxicities, are those toxicities manageable? Is the anemia, the thrombocytopenia manageable, or is it prohibitive? Are we getting to where patients are bleeding or getting transfusions? That might compromise, even though you're meeting success with responses, but you're having side effects that are not manageable, and that's problematic. So, as doctors who treat cancer, whichever cancer is, we switch therapy when therapy is not working or side effects outweigh the benefit. And that is the same case here. If patients are not getting hitting their target and getting their benefit, then that's not successful. You probably should switch. And if patients are hitting their target, but they're having unacceptable side effects, that's time to switch. And that becomes really the general statement. There's a lot more details to this. There's many maneuvers. You could reduce rux and see what happens. You could stop rux and see what happens. But again, in general, these are the guiding principles of when to switch therapy.
And how do you choose your second line agent? I think you've hinted at some of the things that favor one JAK inhibitor versus the other. So is it always a JAK inhibitor in second line and beyond, or are there other treatments that may not be FDA approved that you turn to?
So again, honestly, this is probably the most important question: is how do we choose a second line? Because for almost most patients who have so far have had first-line therapy has been ruxolitinib for thrombocytopenia preserved patients and pacritinib for severe thrombocytopenia patients. And then after patients progress, and they always do, is it where would you choose a second line? And for that, all JAK inhibitors are approved. And that's become now an option where there's more than one right answer. There is more than one correct answer for most patients now. So momelotinib is an excellent drug for second line after ruxolitinib and has anemia benefit. Fedratinib is an excellent drug after ruxolitinib failure and has exceptional response rates, but it does cause anemia and thrombocytopenia. But again, it does provide a very rapid and significant spleen reduction. So as a bridge to transplant, fedratinib can be a useful drug in that space. And pacritinib is a very safe drug to deliver in patients with the lowest counts, the anemia and the thrombocytopenia, even transfusion-dependent patients. And it also has additional benefit in anemia improvement, in addition to spleen and symptoms. So there's really becomes multiple options, and in the quick take-home point is that if patients continue to have good counts, and you're trying to give them a quick response to achieve, maybe a bridge to a transplant, and you're very comfortable managing side effects of fedratinib would be a useful agent in that setting. Although momelotinib can achieve the same benefit without the toxicities and also without the anemia. Momelotinib is a preferred agent with anemia, especially the more severe anemia, given the magnitude of hemoglobin improvement we see on momelotinib. And pacritinib is a preferred drug in patients with dominant thrombocytopenia, but momelotinib and pacritinib have overlap when patients have anemia and thrombocytopenia, because both have safety with platelet counts being low and anemia benefit. So again, it is good that we have multiple options. Sometimes there's pathways that decide or insurance preferences, but sometimes there's more than one option that we use. Now, for patients who are on therapy and have toxicities that can be managed, that's a different way to answer the question. So if somebody's on first-line ruxolitinib and now they have anemia, and that's unacceptable, you could also choose to keep ruxolitinib and address the anemia. And there's agents that we use in that setting, like danazol and ESA, and there's agents that are on NCCN guidelines but not yet FDA approved, like luspatercept. So there are agents in which we can tackle the anemia and keep a successful therapy going longer. So that has become something that we can use. And then something we did not discuss today, there are a lot of clinical trials that are challenging first-line therapy, challenging second-line therapy. So there's always trials that we can tap into for some patients with therapeutic challenges.
And you brought up transplant a few times. Is transplant for those who are eligible your first line go-to option, or is it something that you still keep in reserve and try the JAK inhibitors first?
So transplant should be done for the patients at their optimum timing, optimum response, actually, not after they fail therapy. So transplant should be offered as first line in patient with myelofibrosis, and honestly, without delay, without significant delay. But the unique thing about transplant in myelofibrosis is that it's probably for transplanters, this is the most elective planned transplant they do. You can choose it, you can pick a date, could be like 3-6 months out. You just do it under the ideal circumstances. Ideal circumstances is when the patients have the most benefit from a JAK inhibitor. So some JAK inhibitor therapy as a bridge to transplant is actually beneficial. There's data that actually improves the transplant outcome in patients who receive a defined therapy of JAK inhibitors prior to transplant, but not after patients have had years of JAK inhibitors who have progressed and failed. If you're saving transplant for that, that probably is not a successful plan. So we always recommend transplant at the patient's optimum response, hopefully within a year of diagnosis, especially in the higher risk patients, or no longer than 2 years since diagnosis in the intermediate 2 risk patients. But generally, this is a strategic decision that you make with your patient. So you're making a myelofibrosis diagnosis, you're choosing your JAK inhibitor therapy, and you're referring them to transplant from the beginning. And then the timing of the transplant depends on many factors. One of them is, there's donor availability and logistical and socioeconomic things have to be resolved, but also when the patient get their ideal optimum response to a JAK inhibitor, and hopefully before they lose that, which they often always lose their response eventually. You don't want to wait. That would be too late for sure for transplant.
And my last question is, there were times in the past when we used to use chemotherapy drugs like cladribine, or we also have HMAs. Do you see utility for these drugs in your practice today?
So for chronic phase MF in this classical presentation, there's really no role for chemotherapy anymore, or low intensity therapy. However, the inevitable outcome of MF is many patients can progress to accelerated blast phase, in which they behave in more of a leukemia-like picture, and they require leukemia-like therapy. And those patients might end up needing hypomethylating agents, BCL2 inhibitors, combinations, or chemotherapy in the right patients, and hopefully followed shortly by a bone marrow transplantation.
Well, I want to thank you very much for taking the time to educate the audience about how you treat myelofibrosis. It seems like there's a lot more exciting happening. You hinted at clinical trials, and I hope I can have you back on the program to talk about those exciting developments in the future as well.
Thank you very much, Ravi, for this wonderful opportunity and this great resource that you made available for our colleagues and our patients. I think Allah will find a lot of value in this website and this resource to help them and help their patients.
Thank you very much.